Many cancer survivors face a higher risk of dying of cardiovascular disease than they do of recurrent cancer. This is both because cardiovascular disease is the most common cause of death in this country today, but also because sometimes of the consequences of their therapy. So what are the cancer therapies that have cardiac effects? Pretty much all of them, except probably surgery. Surgery rarely has direct cardiac effects, but I think if one groups it in terms of the armamentarium of the oncologist, chemotherapy has been associated for quite some time with the development primarily of a dilated non-ischemic cardiomyopathy, and specifically the anthracyclines and trastuzumab or Herceptin. There are other drugs as well that have been associated with this problem, including high-dose cyclophosphamide and some of the other drugs that are used in conjunction with the anthracyclines and Herceptin. Secondly, radiation, which is the other big weapon of the oncologists, has a number of cardiovascular effects. People have been aware for a long time that radiating the heart often results in pericarditis, which can be acute and then can be ultimately chronic in the form of constrictive pericarditis with thickening and stiffening of the pericardium. And there is data that in patients who were treated some time ago for lymphoma, that about 30% of those patients, if you looked at them several years after their therapy, may have pericardial effusions. These may not have hemodynamic consequences, but clearly there's been a change in the pericardium. Less well recognized is in conjunction with this, radiation can produce restrictive cardiomyopathy and can affect the valves and the electrical system of the heart. It can result either directly or indirectly in tachyarrhythmias and also in sinus node dysfunction and heart block. When one talks about bone marrow transplant, this also can have significant cardiac effects because it often combines high-dose chemotherapy and radiation therapy as well as immunomodulating agents. And when we talk about other novel agents, these include the interferons, other immunomodulating agents, and drugs such as thalidomide, which actually can produce significant sinus node dysfunction. So again, what are the consequences that affect the heart of these agents? Congestive cardiomyopathy we hear a lot about. I mentioned the pericardial and restrictive disease. We also see coronary artery disease, commonly as a result of radiation therapy, and this may take a form that is pathologically somewhat distinct from run-of-the-mill coronary artery disease, or it may have additive effects in people who have other risk factors for coronary artery disease. Valvular heart disease can also be seen, and as I mentioned, electrical disease as well. So let me try and talk about some of the big players, primarily chemotherapy and radiation. In terms of chemotherapy, I think one of the major breakthroughs in cancer treatment was the development of the anthracycline drugs. And in the 1970s, it was recognized that the cytotoxic effects of these drugs were dose-related. And in some really landmark studies, Van Hoff et al. Showed that the cardiotoxic effects of these drugs, which were being recognized at this time, were also dose-related. And that doses of 500 to 550 milligrams per meter square of adriamycin, for example, were associated with significantly increased risk of congestive cardiomyopathy. So this had to do with dose, but it also had to do with how the doses were delivered. And spacing out the dosing could affect it, and more recently, liposomal delivery of anthracyclines have been associated with a somewhat lower risk of cardiomyopathy. And this had significant consequences. While these changes could be identified by measuring ejection fraction over time. And I must say that Yale and Dr. Zaret here played a primary role in identifying that as a technique for trying to identify cardiac toxicity from the anthracyclines. But in people who had significant heart failure, less than half of them survived. So this impacted in a major way on patient survival. What are some of the other risk factors for anthracycline cardiomyopathy? I mentioned total cumulative dose, the way the drug is administered, and perhaps its format, but age may be an issue as well, with younger people being more at risk. One of the ways that the anthracyclines may affect the heart is by causing myocyte dropout. And if your heart hasn't grown to its full potential yet, that may affect you in an even greater way. Also, if you're older and have other underlying heart disease, these effects may be multiplicative. Women seem to be more vulnerable than men, and the association of concomitant radiation therapy may worsen the effects of anthracyclines. Some other, I think, kind of interesting associations are trisomy 21 and black race have also been associated with a particular vulnerability to the effects of these drugs. What about antibodies? I mean, as the anthracyclines were a major breakthrough, Herceptin has been a major breakthrough in the treatment of women who have overexpressed HER2 and have breast cancer. And initial trials suggested that the major problem with Herceptin were infusion reactions. But a reanalysis of that data showed that there were very high incidence of the development of an ischemic cardiomyopathy. In several of the initial studies with trastuzumab alone, the incidence probably ends up being around 4 to 5%. But if you add anthracyclines, the incidence is considerably higher and may reach 20% or high teens. The good news is that with standard heart failure treatment, many of these patients improve, and that in fact one can reinstitute Herceptin with careful monitoring and give the patients more drug without producing further harm. And again, risk factors, these are mostly women. This is a study of women with breast cancer, but virtually 100% of these women had received anthracyclines amongst those that developed cardiomyopathy with Herceptin. What about radiation? I mentioned pericarditis, and I think that's probably the most well-known consequence of radiation therapy. There are risk factors for radiation-induced heart disease, and once again, these are total dose, higher fraction dose, direct focusing on the heart by the radiation beam, whether or not the heart is shielded. Similarly, younger age, time since exposure, and I would emphasize that risk for all of these problems does not go away. You know, if you get out 2 years after your treatment, you're not home free, and the risk accrues over time. The combination of chemotherapy and radiation also plays a role. And lastly, and I really want to emphasize this later, other cardiac risk factors. And Dr. Rowland spoke to this, that there are some things that we can change. We can't change that someone has cancer. We can't change that we have to treat them and try and treat them to have them survive. But we can emphasize to people that they stop smoking and that their cholesterol is well managed and that they exercise. And those are very important things. I think we have to be cognizant that the people that we're seeing today received treatment by modalities that we're not using today, and that the goal is to focus the therapy to cure the disease with the least lethal or toxic doses possible. To talk about some of the under-recognized complications of radiation therapy, this includes significant valvular disease with pathologic thickening of the valves, calcification of the valves, and predominantly regurgitant lesions over time. And this study followed people getting radiation therapy for lymphoma, and over time, up to more than 20 years, there was significant increase in the risk of aortic insufficiency, primarily, and mitral regurgitation to a certain extent, and aortic stenosis, which kind of goes together over the general population. And these risks are significant. Electrocardiographically, there are many electrocardiographic abnormalities that can be associated with radiation. Right bundle branch block, the anterior portion of the right bundle is right under the chest wall and maybe the site of the highest dose of radiation. Abnormal Q waves, which may be from a myocardial infarction. And as I've said before, often we see atrial arrhythmias in association with pericarditis. People may have ventricular arrhythmias in association with the development of dilated cardiomyopathy or myocardial infarction. And lastly, we see heart block, which is a well-described complication of radiation, and sinus node dysfunction. How do we monitor for toxicity? Well, I think there's the obvious. You talk to the patient, you examine the patient, you look at their electrocardiogram. Those are the simplest things. And I think we're still sort of groping with what's the most sensitive way to identify potential toxicity or the beginning of toxicity without so limiting therapy that people die of their primary disease. And I think most people agree that endomyocardial biopsy poses too much of a risk, and that studies such as dobutamine stress tests may be too sensitive. But there's the tried and true has been echocardiographic follow-up and radionuclide follow-up of ventricular function. And serial studies have proven to be valuable in terms of identifying a point to stop therapy. There is new interest in looking at troponin levels and some data that people who have elevated and persistently elevated troponin levels in the face of chemotherapy or radiation may be at increased risk for the development of myocardial dysfunction. Can we prevent myocardial toxicity? This is clearly the big question. As I said earlier, reduction of other risk factors is clearly very important and something that we can do. Nobody should smoke. People shouldn't say to cancer survivors, well, you survived your cancer, so it doesn't matter if your LDL is 140. You know, they really need to pay particular attention to that. And exercise and treatment of hypertension are all extremely important. There are a number of promising agents. Data for these are less than robust for many of them. And I'll just show you some of them that have been looked at in terms of preventing anthracycline toxicity. Dexrazoxane is probably the best data, I think, in looking at all of this. There is a little bit of concern that this agent, like the other agents, which are either chelating agents or antioxidants, which is what is believed to be the mechanism of anthracycline toxicity, you don't want to give a drug that interferes with the chemo cytotoxic effects of on the tumor. So it's very important to make sure that if you give something that's myoprotective, that it's not also tumor protective. And so data is looking at that carefully. In terms of standard heart failure data, there's some interesting data from Cardinale, who looked at people who, again, received high-dose chemotherapy in terms of looking what happens if you put people on ACE inhibitors, which are one of the mainstays of heart failure treatment, and that if you look at people who have persistently elevated troponin levels and therefore would be considered at risk for the development of cardiac toxicity, if you treat them with ACE inhibitors, that they have less troponin elevation and that the troponin decreases sooner, all of which was associated in their preliminary studies with a decreased incidence of clinical cardiac toxicity. So there's some interesting data out there. I don't think as yet we're ready to say that everybody who gets an anthracycline or Herceptin should be started on an ACE inhibitor immediately, but it's something to think about. In summary, I want to emphasize that I think the goal of cancer therapy must be to hone down on the tumor and try and really, provide stealth bombers to get the tumor and try and limit the collateral damage. But I think people have been so successful in doing that people are living longer, so we have to make sure that we pay attention to all of these other issues so that they live long and healthy lives. Thanks very much for your attention.